Meet Alicia, a 28-year-old with asthma who forgot her rescue inhaler. By midday, smoke from burnt popcorn fills the hallway. Within minutes, her chest tightens, her breathing becomes labored, and she starts wheezing. First, notice what matters. Alicia has classic asthma symptoms: wheezes, shortness of breath, chest tightness, and cough. But the key finding is decreased breath sounds on both sides. Wheezing means air is moving, but decreased sounds mean decreased airflow. If breath sounds disappear, or silent chest, it signals impending collapse. Her thick sputum reflects inflamed airways, producing excess mucus. Peak flow and pulmonary function testing are sharply reduced, confirming severe obstruction. Now interpret what's happening. Asthma is driven by three processes. The airway smooth muscle tightens, causing bronchoconstriction. The airway lining swells from inflammation, and thick mucus partially plugs the airway. Air can get in, but it cannot get out. Air traps, lungs overinflate, work of breathing rises, and gas exchange suffers. Over time, repeated inflammation causes scar tissue and permanent loss of lung function. Triggers like smoke, allergens, infection, exercise, and cold air all provoke this condition. Next, respond. Acute symptoms are treated first with rapid bronchodilation. Short-acting bronchodilators like albuterol relax smooth muscle within minutes. Anticholinergics like ipratropium can be added to enhance bronchodilation. Systemic steroids are started early to suppress inflammation, even though their effect is delayed. Other controller options include leukotriene modifiers, long-acting bronchodilators, and anti-IgE therapy. Prevention matters. Trigger avoidance, daily inhaled steroids when indicated, and never using non-selective beta blockers. Now let's reflect. If Alicia improves, her breathing improves. Instead, she worsens. Her wheezes fade, she can't finish sentences, her consciousness drifts, and her carbon dioxide rises. This is status asthmaticus, an asthma attack that no longer responds to standard therapy. Severe air trapping causes hyperinflation, rising chest pressure, right heart strain, and respiratory muscle failure. Everything escalates. Continuous bronchodilators, systemic steroids, and epinephrine are used to force the airways open. Intubation is a last resort because ventilating an overinflated lung can cause collapse or pneumothorax. In summary, asthma is a hypersensitivity response causing bronchoconstriction, inflammation, and excess mucus, which obstructs airflow and impairs gas exchange. Think wheezing and dyspnea, and treat it with bronchodilators and steroids. Status asthmaticus is unresponsive to treatment, leading to risk of respiratory failure. Treatment includes epinephrine IM, continuous albuterol, and mechanical ventilation if necessary. If you study to remember, you will forget. But if you study to understand, you will remember. Author unknown.